Hello and welcome to IGPP Expert Talks. I am Heena Goswami, editorial consultant with IGPP, Institute for Governance, Policies and Politics, New Delhi. At IGPP Expert Talks, we have been engaging with experts from various domains of AI who are committed to ensure that the AI technology is leveraged in a way that is most beneficial to society at large. And today, to shed light on how AI can be leveraged to improve healthcare, we are joined by Dr. Geeta Manjunath. Dr. Geeta Manjunath is the founder, CEO, and CTO of Niramai Health Analytics, known for its AI based, non invasive breast cancer detection test. She has received notable awards such as the CSI Gold Medal and Birack Winner Award 2018, and she has featured on Forbes Top 20 Self-Made Women 2020. Dr. Manjunath was also honored as the Accenture Vahini Innovator of the Year and Women Entrepreneur of the Year 2020 by Biospectrum India. She has co-authored Moving to the Cloud and holds 20 US patents. Welcome to IGPP Expert Talks, ma'am.
Thank you, Heena.
How can artificial intelligence enhance precision in diagnosing life-threatening diseases such as cancer, where accuracy is of paramount importance?
Yeah, so first of all, thanks a lot for having me on this show. AI has been my expertise and skills, in my previous organization as principal scientist at Hewlett Packard Labs and lab director at Xerox for AI as well. And now as founder CEO of Niramai, where we are literally sort of trying to see how AI can change the way healthcare is being delivered, healthcare is being offered, and how healthcare can actually be impacted, more from affordability, accessibility using AI. Now, when we talk about precision in cancer care, right? First and foremost, every patient is different, right? Every patient has so many aspects in which we can define the specific, maybe the cancer stage she is in once it's detected, and also the kind of genomics, that they bring in, and there's so many other treatment variations, the dosage of chemo, etc., etc. So starting on the other side, assuming a person is already detected with breast cancer or any other type of cancer, figuring out precisely what kind of a treatment may be most effective, because especially if it's late stage cancer, we don't have time to experiment different treatment methodologies, right? So the doctor has to decide once, and hopefully it is the best one. Of course, they still may have to try out different methods to ensure that the person has the complete cure, but the experimentation method would be much lower. The experimentation itself will be much riskier, and so on and so forth. So first and foremost, where AI can help in precise medication for the cancer is to, model the patient in a way with different, what we call as omics, right? Genomics, radiomics, what we have defined as thermal radiomics, etc. Vascular radiomics, we call it. And so many, right? Biomarkers, either from an imaging standpoint, blood SAM standpoint, or genetic standpoint, or more, right? So first is modeling the patient with different parameters that we are able to perceive with sensing through multiple methods, which I mentioned. And then looking at cohort of patients before, that is, how did such a patient who has this genetic markup, this, imaging signals, and so on and so forth, how did that person react to a treatment, So looking at historic data about how patients of similar cohorts, right, behaved, then you try to start with that treatment first, So this is one place where precision medicine, what we call as, where AI can make a great impact. So that's on the FAG and or the treatment and so on. Where we are, definitely early, but there's a huge potential for AI to make an impact is also on the wellness aspect, preventative aspect, right? Where people feel we are all normal. We all think we'll not get cancer, right? But any one of us can get cancer any day, right? Because it is such a big disease today, and especially breast cancer is the top cancer in women, right, across the world. So now, how do we know out of these 100 people who are the 4 women or maybe more, right? Maybe 33 women who may have some kind of cancer. So this is uh, is one thing that we can do with AI as well. One, again, going back to all the demographic information and figure out, firstly, using AI to figure out who has the highest risk and then monitoring those people. Right? Secondly, by doing certain early detection screening, because we all know that early detection is very, very critical to have a better treatment efficacy. If we can detect a person's cancer in stage 0, stage 1, then we have a likelihood of 95% survival rate, especially for breast cancer, which means that nobody needs to die of breast cancer. All they have to do is to detect in stage 0, stage 1. How is it possible? You cannot have a doctor looking at every one of the 2 billion women who need to be screened, and we are doing it at every year, right? That kind of a scale of need today, we are not able to support using our existing skilled force in medical field, right? So that is where, again, AI-enabled robotics or AI-enabled simple healthcare workers, it's almost like you are artificially improving the skill set of a health worker by giving an AI tool to them. And then these people will be trained to use the tool to say whether there is an abnormality or not. And once we figure out a person has higher risk or has shown something like abnormal, may look like cancer, it may not be, then we can bring those subset of people, which could be like 4%, 5% of them, and then bring them to the full medical care in a diagnostic center or a hospital where there's all the information available. So here again, to triage the patient, to identify high-risk women or people in general cancer, so that they could get the right treatment or initiate the treatment at the right early stage. That's another huge potential where AI can impact, where particularly we at Niramai are looking at for breast screening as well. I can go into more details, but at a high level, I think in the whole, what we call as care continuum, starting from wellness, where everyone looks okay and you're trying to figure out who is probably not okay, be it with just demographic-based risk assessment or imaging-based risk assessment, genomic-based risk assessment. So once you do that, bring them to the next stage in doing. And again, during the diagnosis as well, the imagings that we use, right, could be an MRI, mammography, CT scan, or a thermal where we are using ultrasound, all of these, right? They are imaging tests where human eye always has a limitation of looking at smaller patterns. So now here again, AI coupling the radiologist's skills to make the diagnosis itself more accurate, reducing the missed diagnosis and misdiagnosis. The difference is that we missed a cancer and sometimes we over, diagnosis because we are like, oh, it looks, and then tried sort of over treatment. So there again, AI can. So wellness during diagnosis, during treatment as well, you can monitor the treatment progress and to even decide what treatment to do. All of these cases, right, in stages of cancer, making it more and more precise, the result is where AI can definitely help. And I'm super excited about it because it is one of the deadliest diseases nobody wants to get, right? But if one gets it, unfortunately, we have to be having all the tools necessary to catch it early and treat it early and make the person live longer.
In a nation like ours, when we talk of healthcare, we cannot but talk of, the price associated or the
Yeah,
cost of it.
yeah.
Right? So what would be the cost implication of adopting AI in cancer detection and diagnosis? And is it a technology that can be leveraged only at like high-end world-class hospitals, or would AI help make advanced diagnostic more accessible in low resource setting as well?
Right. So it's a good question. So when AI is used to make a test which is already being provided more accurate in diagnosis and so on and so forth, there it may actually add to the cost. For example, if you say the MRI is being done and you need AI enabled analysis of it, the radiologist anyway is looking at it, but AI is doing some initial analysis and then, providing it. However, the effort there is to say that AI has done maybe 50 to 60% of the job already, and the time the radiologist takes on that particular image or a particular scan of the patient is much lower. So one on the fag end, like more towards the treatment and diagnosis stage, AI is first making it more accurate by imaging, analysis, and so on, and making the time of the radiologist reduce, right? From that perspective, there is a cost implication. But the imaging test itself is the same expensive MRI or mammography that is being done. However, efforts like ours, there are others also in eye care. You can see that AI being used from a preventative aspect. I told about multiple aspects where AI can impact the cancer care. And I think in the initial stages of screening and diagnosis, if we can use AI, there are instances where we are seeing that AI can actually reduce the cost. Because, as I briefly alluded to earlier, we are trying to make these tools, making these AI tools more like helping simpler health workers, lower skilled health workers to basically utilize the tools to become more smarter in some sense, right? The human plus computer being smarter than the human, right? So that aspect of it, using it at a healthcare worker level definitely will reduce the cost drastically, right? And once we have automation, obviously, there is human involvement reduced and so on and so forth. So that, also will reduce the cost. So depending upon where AI is used, the attempt would be to make the accuracy higher and the cost lower. The cost could be lower because we are using the doctor's time lesser. But more importantly, once you scale, several of the things which cannot be even done in today's, economic status, especially for certain countries, becomes feasible. So today, if you see India or some of these countries, only 10% of the women are being screened with a technology-enabled solution for breast cancer. Now, by adding AI-enabled tools and things like what we have developed, like thermalytics and all, we're able to increase this reach to many, many percentage higher. Hopefully, at scale, we can make it like 90%, right? There is a possibility. So this, again, it's not like at this stage, was I spending more and have I reduced? But some things you couldn't have even done feasible, right? That we make it feasible because of affordability. So per patient cost definitely is reducing with AI, both from a preventative and a treatment and diagnosis perspective.
Ethical implications
ethical, okay.
of relying on AI for breast cancer diagnosis in care, particularly when it comes to data privacy, bias, and informed consent of the patient.
Oh, this is a huge one, right? Especially when we talk about AI, there is no AI model if there is no trained to the AI, which means that there is data of previously diagnosed patients as either positive or negative for cancer. And that data is used for training the AI model. Now, the ethical consideration comes in different phases of this AI training, AI testing, and rolling out in commercial sort of setting, and so on and so forth. Let me start from the training aspect of it itself, right? So what's very, very important is the type of people you're likely to test or use the AI model on should be the type of people on which or from which, like the data from these kind of people is what should be used to train the AI model. Then what we call as the probability distribution of the training set and the test set would be somewhat similar. So because AI models are generally probability and statistical models. So that it's important to have a similar distribution, or the AI model should be generalized enough to address slightly variant distributions, right? And there are techniques to do that as well. So that is one place. Like how the training itself was done is definitely an ethical consideration. You go into a tertiary care, figure out all the late stage cancers, and then you kind of train the AI model to catch, late stage cancer, but won't use it in a preventative manner. Then what happens? The AI model is only trained to catch late stage cancers. So it will miss early stage cancer. So it could be stage wise as well, or it could be you train in Indian patients and then go and use it on US patients. There again, there is a ethnicity related possible biases that may come in. So the bias part which you mentioned is also other aspect of the ethical considerations that. And the third bit is the consent, which you also mentioned very, very clearly. As an end user, as a patient, do I know that my data is being used by this tool to help become better for another person, which is fine. Most of us may be okay with it, as long as, nobody knows that that image is from Heena or Geeta, right? The anonymization of the data is very, very. So one is consent from the end user saying, yes, it is okay. Even if it is anonymized, you can't assume that if it is anonymized, I don't need to ask her. No, right? Even if it is anonymized, the patient has to know that, the data will be used. So user consent for almost every screening is important. Sometimes it could be implicit screening, implicit consent, because the person has done registration first itself. When you register to a hospital, you actually fill a lot of form and you are knowingly or unknowingly you have said it's okay to use my data like one time. And then every time you come to the hospital, pay the bill or whatever, take the receipt and pay the bill for the test, you're already consenting to it. It could, while that's fine, usually, because there is a broad consent that is given. What we do, for example, in Niramai is that every screening camp, irrespective whether especially when we are interacting directly with the customer or the end user, we do take consent, explicit consent. It has to be informed consent, right? It's not like, hey, Heena, I'm taking this thermolytics test, you sign. And so many times when you're doing doodle skin, they just sign. But we have to explain to the user, this is what we're going to do in the test. This is what we're going to do with your data later. And then we are going to use your data, first of all, to generate the report. Next, we may use it for our research purposes. And it has to be done in the language of, choice of the end user. That is the language that the person understands. And so all of this is super important. And I would add one more, I think there is ethical consideration in the AI development as well, right? Development of the AI model itself, because especially when we're talking about clinical decision support systems powered by AI, like a cancer detection tool or cancer, even like treatment planning tool and so on. It's very important for the development team or the founder, whoever is responsible management, to ensure that adequate testing has been done. Adequate clinical testing has been done, right? Not on only, let's say, 100 samples and I've done, yeah, that's one. Not just retrospective, right? In a prospective manner, in a way that it will actually be used in a hospital setting or a rural camp setting, right? So, there are different levels of testing, clinical testing, prospective, retrospective, observational. Best one is, RCS, right? Essentially randomized controlled trials, RCT, as we call it. So all of this is very, very important to have. More testing you do in a condition where it is likely to be used, a similar condition, like a field testing, by the right kind of people who are using, not like a scientist going and doing it or a doctor doing it. If a health worker is supposed to use it, health workers should be doing it even in your clinical study. So all of this is very, very important. It is, in my opinion, also an ethical consideration that every AI developer has to do it. So there are more, I can go on, right? There are so many aspects of ethics we should consider. But I would just say one line and stop answering this question is that for all the AI developers, commercial or technical, right, we should always keep the end user in mind, right? Saying, I am responsible, ethically responsible to make whatever I can, as much as possible, to make my AI model correct for that end user. Not for the money the doctor is paying at the hospital, but you're doing it for that end user. Would I put myself there? Would I put my mother there? Would I put my father, my family, my spouse to use that? So if you consider it that way, then all the things will align. You will actually use the right training, right testing, right model building. All of it will align, right? I think keeping the end user in mind, all the ethics will fall in place is my personal opinion.
So at this moment, when we are talking about using AI to detect and diagnose cancer, can we go a step further and can we envision a future where AI becomes the source for primary consultation and doctors are relegated to sort of secondary role?
So actually, in my opinion, AI tools will always be used by humans. Whether they're doctors or lower skilled, that may change, right? Depending upon the context in which it's used, right? I think that's important. Especially, it's all about what is it today and how are we going to change it, right? For example, if I have to talk about breast cancer, where I've spent 7 years now, just looking at AI for breast cancer screening. If you go to a rural area, how is breast cancer detected? Worst case, they don't even know what is breast cancer, right? They don't even know what is the symptom. They just accidentally find such a big blob, like 5 centimeter blob in the breast, and then they say, oh, there's something going wrong. Or maybe blood oozing out and they can't hide, they have to talk about it and then they go in. That's sort of the one really worst case scenario, but that is how it is in so many parts of India. Next, a health worker coming in, and this is the standard what I'm going to talk about. A health worker coming in and doing clinical breast examinations, a hand-based examination. And this is the guideline in the NICPR, National Institute of Cancer Prevention, or ICMR, it's part of ICMR, which says that hand-based examination is standard for India for rural screening. Now think about it. Instead of this, if the same lady is given a little bit more sophisticated tool, which can not just detect 2 centimeter and above, which is stage 3 and above, or not just detect all lumps, which can be so many, 60% of them being false positive, but it can give her a tool which can actually identify more precisely the people who need to be brought to the next level. Why not? Why can't this AI tool be used by a health worker who is a non-doctor? And I think here the triaging use case, especially in countries like ours, where there is really, what is the current state is what I mentioned, right? Over that, this is definitely superior. Ideally, yes, I want every clinical examination in every village to be done by a doctor. We don't have that luxury. We can't even do that in an urban city where we have more doctors. So in that context-based usage, yes, AI tools are already being used with by humans. I mean, I'm not saying automatically it's saying something and people are right. That is still not there. We'll see at what stage we'll go. But there is a human supervision. A human is a trained human. It may not be a doctor who's doing the triaging. But for the diagnosis, it is going to be the end diagnosis treatment. Definitely, it has to be really, really an expert, for which, the secondary would be AI, which is helping as a agent, or helping as like an assistant, we would say, right? Where they can do a faster diagnosis, more accurate diagnosis with it.
I completely agree with your assertion that, having coming from a rural background myself, I know that in rural settings, the interaction with doctor is at a very late stage. It's only the primary healthcare workers who are taking care of you,
Yeah,
compounders, nurse, medical assistants who are taking care, even prescribing medicines at
right.
primary healthcare centers. So doctor, like it's only in cities that you go, fix an appointment, go to a doctor. In villages, I've seen like nurses set up their own sort of semi-clinic sort of setting where
Okay.
yes. So I mean, and doctors are rather hard to find. Like they
Yeah,
have
then no, like one doctor for 1,000 families is what I know is the
true.
statistics in many
And
villages.
so I think it would be really helpful for those nurses, for
Yeah, exactly.
compounders to have that kind of technology where
Correct.
you already have the trust factor with them, but for technology to intervene and to make sure that, it's right, like what the diagnosis they are doing, or the treatment they are providing, or the kind
Correct.
of care they are providing, that is
Correct.
technologically also correct. I mean, that would be very helpful. But I also want you to shed some light on the kind of challenges that are associated with applying artificial intelligence in the diagnosis and prevention of diseases.
Yeah, there are several challenges. First and foremost, there are not many successful, instances or use cases of it to learn from. So people are experimenting, and in fact, Niramai is many times appreciated for being one of the first few who were able to do all the things that we talked about. And it hasn't been easy, and it's not like somebody decides, yes, I'm going to do it, and go to the village and do it. You did ask more ethics, right? It's about, am I doing this testing with the right type of cohort at the right time in the development of the product itself? It's not like the first year you cannot go and do it. Maybe you can, as long as you put all the risk mitigation techniques around it. I'll give you an example of how we started off doing it. Like challenges really is about what is the pathway to roll out? When is it the right time to roll out for this one, right? So what we did was, I mentioned that was hand-based examination. So we partnered with a cancer society, Karnataka Cancer Society, who were already doing like a standard guideline, hand-based examination for breast cancer. And then I went to them and showed them we had done many testing, like retrospective and prospective testing in a hospital setting, but not in a field setting, because you can't take a mammogram to a field and do a full head-to-head comparison. So I told them, like, we have proven this much in a hospital setting, and now I want to be able to roll out into the field. What else can we do? And then they'll really like what we have said. And like you also mentioned, a healthcare worker, now if he or she is coupled with a technological tool, it's always better. So we went with this notion that why can't I use the hand-based examination and our test both? And we will get people who are positive in either this or that. We're not ruling out the existing, but we bring them. Maybe, yes, we'll bring a few more people as positive than earlier. But when we started rolling it out this way, we found that we were actually helping out. We were actually finding other cancers which were not found by hand-based examination. We were actually also saying that this particular lump you found was not really required, like a malignant lump that you had to get it. Initially, we just brought both of them, but when we started doing this rolling out and getting the positive patients go to ultrasound, mammography, and biopsy, we could make of that that there is an increased confidence. We also learned, in some cases we were doing false positives. We kind of had to fine tune it, but over time we figured out we are ready. We are ready for it. So this rollout testing process without impacting in a negative way the end users is important, right? And that's a challenge. And it can be different for different projects, different models, different techniques, or definitely diseases, right? So you need to identify the low risk for whom? For the end user. You're not spoiling somebody's health by doing it, right? Trying to help, but not spoil the health, right? So you need to figure out that pathway of easy rollout, validation of the rollout, and then we can do it. I think that's the main challenge. Apart from that, data is always a challenge. Finding the right kind of cohort data for training your model, testing your model is right challenge. Another challenge is that when you actually do the head-to-head comparison with the standard of care, mostly you have to do it in hospitals. Not every hospital is incentivized to do clinical studies. Finding the right place for doing clinical studies. Doctors are so busy finding the right expert doctor who is willing to do the clinical study with you, spend the time to help the technologists design the right protocol, and then also money, right? You need a lot of funds to do large scale clinical study. People say, have you done an RCT on 50,000 patients? I want to do it. But who has the money to do it, right? Who has because you have to hire people. We can't do it free of cost. It will come there, right? It's not that until you do an RCT of 50,000, you cannot roll out. Like I said, there's always a risk mitigated way of rolling out that you can do with experts, along with experts. So these are some of the critical issues. Another thing is more regulatory, right? Every country has a different regulatory process. So, many countries have not even figured out how to control or regulate an AI-based model, right? And because we need a lot of expertise in different way, and the AI could be more like a black box, right? How do you know what it is doing internally? Like the developer may say we are doing this and set the results, but that doesn't mean we can peek into it. So how can we make AI models more transparent, more what we call as explainable? It's able to say why it is saying somebody is positive. what is the process of decision making. They have to be more explainable, more transparent, and so then only the regulatory people can validate it. And it's a little bit of a difficult situation, because if you're too transparent, your competitive advantage is lost. Why do we do all the patenting and so on and so forth, the trademark, all of that. So we have to be we have to have the right kind of balance. And last but not the least, AI learns over time, right? So we know that, like, people become better over 1 year, 2 year experience and things like that, over years. AI also can become better and better if you actually feed its wrong decisions and tell them this was wrong, and tell the model that it's wrong, and you can build it, right? It could be online learning or retraining. All of that can be done. But what is the guarantee that this AI, which is learning on the go, is actually going to be better than the previous AI model that was running? So this becomes very difficult. And even today, there is no regulatory body which has approved AI online learning models. We only today have clarity on locked models. That is, models which are locked, trained, locked, and then released. And if you're doing retraining, you have to test it and lock it again. So there's a lot more to be done yet, because we have only early rolling out of it, especially the question about, is it AI plus doctor or AI plus health worker or AI alone, right? AI alone is a long way to go from a regulatory standpoint and rollout standpoint. But yeah, it's definitely helping. We see a huge growth potential in that direction still.
My last question, ma'am, is that in this tech-enabled healthcare, how can Internet of Medical Things combined with artificial intelligence enhance and transform the overall structure of healthcare delivery? And I would like you to begin with shedding a little light on what is the Internet of Medical Things.
Yeah, sure. So, so people have heard about Internet of Things, IoT, which is basically usually small devices, small sensors. It could be big as well, which are placed in different places. These are device sensors, which are also having internet capability. So it could be simplistically taking like a pressure sensor or a temperature sensor or rainfall sensors. You can think about those, which are placed in different cities, villages, etc., and it's measuring something and sending that data to a central repository. We're saying, and then there is some kind of a GPS angle to it. That is, the location from which it is coming in, right? So for example, it's a pressure sensor, just to sort of make it, you measure the pressure and then send, okay, at this GPS coordinate, that is latitude and longitude, this is the pressure, and you're sending it at a particular time. So the time, the value, all of that, and it is internet enabled. So it automatically goes to a central place where you collect all the data and start looking at, how is the temperature, pressure around this particular area. So that's Internet of Things. Now, IOMT is Internet of Medical Things. Think about that happening on the human body, right? And so how can, of course, it can be different humans and so on. There's no GPS, maybe it can be, but not necessary. But it's more about sensing things about people and setting it over time. What becomes more important for human beings is to tracking over time and tracking and sensing over time. So there's so many things. You can wear an Apple or a Samsung watch, and it is actually already sensing so many aspects, including your heart rate, number of steps you walk, and obviously SpO2, possibly BP, whatever. In a short while also we have sugar patches, sugar glucose measuring patches, etc. It could be these kind of wearable devices which are measuring, sensing the body and sending it to a central place. And here what is happening is there's also anomaly detection. What is a normal change in normal things in a human body over time, and every person is different, right? You may be different. So for this, based on the historic data of, let's say, my measurements or your measurement, you can make out what is an anomaly, what is looking like, oh, heartbeat should have been around this one. Why is it showing as a peak, right? Or a spike. And that's something that, anomaly detection algorithms can be done. And then whenever that happens, directly a doctor gets a call, or an expert who's, viewing this case. So this is one way of how Internet of Medical Things come in. But now it's actually, IMT is sort of broadening to be any sensing, for example, right? Even for example, if I'm doing an X-ray of my chest, or thermalytics, thermal scan for the breast, or any other. So those also can be considered as kind of mega sensors, if you will. And the time frame also could be every 6 months, or every 3 months, or every month. Nobody does this kind of imaging every day, but yeah, I mean, in a very dire situation, you can do it. So, the scope could be broader, but yeah, so here, this is very, very important because it allows precise measurement of different parameters, not just a lab test that is taken once in 6 months, or an imaging test that is taken. And so even the imaging test that is taken can be used as a context of measuring the daily, measurements of vital signs or any other things that we do. So can think about it as collecting data easily and efficiently in continuous, manner, so that we can do more and more precise treatment for the person. We can actually have the intervention done at the right time, because there is somebody else automatically kind of monitoring the status of every person. More so for post-surgery patients, palliative patients, many of these, there is a requirement for continuous monitoring high-risk patients in general. So all of these, it will be very, very